So we're starting out with the PowerPoint, week 8. We're going to go into the GU system and how do we assess it? So we know that a simple urinalysis can look at blood, can look at protein, sugar, can look at protein. And all of these things are going to be giving us a sign, is there something going on with the body? So really interesting. Just a simple urine tells a lot. Ultrasound starts looking at structure. IV pilogram is usually used for kidney stones. IVP is what I normally have seen them ordered for. CAT scans are done to look again. Biopsies. Is there an infection? Is there a tumor? Cystoscopies, looking with a scope into the bladder. And then avoiding cystourethropography is usually used in those young children that have had frequent urinary tract infections. And what they're looking for is dye moving back and forth and flowing between ureters and the bladder and the ureters and the kidneys, their backflow going on. And that's when that's usually done. And then, other tests that are looked at. So what are some of the terms? We're always going to have vocabulary, and we can actually pull questions apart just knowing things. So this is difficulty in urinating, dysuria. Frequency, frequency. You're going to bathroom urinating quite a bit. Urgency is when you can't hold it and you have to run. We see that a lot with your urinary tract infections. Enuresis is bedtime wetting. Now, there's a couple type of enuresis. Is it due to diabetes insipidus? Is it due to diabetes mellitus? Or is it a urinary tract infection? So we really have to look at these, figuring out why are they going on. Polyuria, urinating a lot, and oliguria, you're not urinating. So understanding definitions are important. Now, phimosis is a male that's uncircumcised, and you try to pull the foreskin down and you cannot. Now, the problem with that is that if we don't pull it down and clean it every day, you're going to get an infection. There is something that's called this white cheese-like substance that forms between the foreskin and the penis called schmegma. It is like a petri dish. It wants to grow bacteria. And because it's holding in that skin up into the urethra, we're going to get some of that bacteria going into the urethra, into the bladder, and causing infection. So we want to make sure that we correct that if at all possible. Now, sometimes we pull down the foreskin and it sticks. It doesn't go up, doesn't go down. And that's called a paraphimosis. That's when you put it down and it stays there. And we need to get it back because it's like putting a finger on a bleeder that stop it. You're like tightening the penis and you're restricting blood circulation. So it will swell, and then there's no blood, and then a lot of other problems could occur. Now, epispadias and hypospadias is again a male. It's their penis. And epispadias is somewhere on the top of the penis, is where that urethra that should be at the end is up here. It's not there at all. It's up here somewhere. Hypospadias is on the underneath part of it. Okay. It can also be that cordy too, which is, the shape of the penis. But what they do with this is you need to keep your foreskin because the foreskin is used for plastic closure. So you have some cultures like the Jewish faith that like to do the circumcision, that's the breast, right after birth. But we can't do that. Especially if you have hypospadias or hypospadias, because you need the extra tissue. Because what they do literally is fillet the penis open, create a tunnel, and then they put a catheter or a stent in there, and that keeps that circular the circular tunnel that goes from the bladder to the end of the penis open, and then that child will be able to urinate normally. The only thing is post operatively, um, we do these things hopefully before they're potty trained. So before 18 months, usually closer to 12 months, because they don't want it to impede upon them trying to potty train. Can you imagine a little boy going into the bathroom, trying to pee in the potty, and it's going directly straight up instead of down because it's not on the end of the penis, it's on the top or on the bottom. So we try to do it before then. Now, atrophy of the bladder. All this means is the bladder was born on the outside of the body. We usually can see this in ultrasound, but if it's real tiny, maybe or maybe not. The problem with this sort of condition is a little urine can leak and it could lead to irritation of the tissue. So we need to make sure that we keep that area clean and moist and protect that skin integrity there. So you can put the kid, position right, left, in the back, but not on the tummy. And because of the chance of infection, we want this closed within 2 days, 48 hours. Now, obstructive uropathy is when there is something that impedes the flow of urine from the kidneys down into the bladder and out. There could be stones, right? Kidney stones, they hurt and they're going to block urine. Could be tumors, strictures, or even scarring from previous injuries. Hydronephrosis is when, the kidney gets small and it's not functioning the way it should and it gets fluid in it. Polycystic kidneys when there's cysts in there, which means it's not functioning to its full capacity. So one of the things with obstructive uropathy, we want to make sure that, again, before they're potty trained, that we fix it so that the child can urinate in a normal way, okay? And let's say and I love this, school-age children suffer from being different. Can you imagine if we had that epispadias, hypospadias, we didn't fix it, and somebody else saw him urinating into the urinal and it's going in the wrong direction? What would happen? He would be teased incessantly, right? Also, adolescents. Can you imagine now they're sexual? They're not going to ejaculate in the normal way. It's going to be in this different manner. So we like to get it done as soon as we can. So you have a 4-year-old boy. He's explained to the clinic nurse that for weeks, child's been irritable, listless, developed poor appetite, and he's gained weight. What signs and symptoms should the nurse look for? And what conditions should the nurse suspect? And what interventions? This is very broad and a very open type of question. What sort of conditions causes you to gain weight and get irritable and you're swelling? That could be, where your kidneys stop working, right?
Kidney, kidney.
Yes, so you're retaining fluid, right? And you're retaining it, you're gaining weight. So what would you look for? Well, intake output and then monitoring that. There's so many different conditions it could be, but I think we put it down to weight gain is fluid balance. Let's look kidneys. They really monitor that. Now, urinary tract infection is very common. Little girls is the most common because they have little short urethras and it's open and it's close to the anus. And little girls love bubble baths. They love cute tights that are get it hot in the perineal area. They're potty training. They can't wipe front to back. So they're taking the E. coli from the stool and it could go up into the bladder, creating a nice E. coli in the urine. which again will show all the signs and symptoms, and it will need to be treated. So, what do you see and what do you do? Well, it actually depends on how old the kid is. It also depends on if we do a urinary tract infection and we see, oh, 10 to 12 white blood cells, or do we see too numerous to count? That will make a difference. Also, is the child awake and alert? How long is this gone for? Or are they listless, irritable? Are they gain weight, right? That would be one now. The kidneys are really showing you stuff that's going on. So one of the things, with children and the young children, we want to give them the IV antimicrobials, the antibiotics. We want it going directly where it needs to go. So we hit that infection quickly. Because remember, they don't have big immune systems. And then older children can go home on maybe they'll have one injection of an antibiotic, or maybe not, and just get oral antibiotics. So that's the thing with urinary tract infections. Now, how do you prevent urinary tract infections? Well, we know a lot of it's about potty training. So it's teaching them how to wipe. That's a big thing. And then with babies, making sure that we do clean after stool and urine front to back, always front to back. Now, this is the hard one. Have them urinate immediately after a bath. Now, how many children do you put in the bath and with the warm water and they immediately urinate when they get into the bath? I mean, that's a common occurrence, right? It's better afterwards. Just like adolescents, urinating immediately after sexual intercourse decreases urinary tract infections. So I said, those nice, tight pants they like to wear, they're cute, but loose fitting pants, white cotton underwear decreases the amount of incidents. And then the biggest thing is keeping the fluid intake, making sure there's plenty of fluid. Now, as I said, there's a lot of things that can cause you to gain weight involving kidneys. Well, nephrotic syndrome is one of them. Now, the first thing I want you to know, nephrotic syndrome it is not kidney failure, right? It has nothing to do with kidney failure. The kidneys are working. But what happens is the kidneys say, protein, I don't like you. So it starts spitting out all the protein. Now, when you get rid of the protein, it's getting rid of the protein in your blood supply, right? And protein is also called albumin. And we know albumin is where the medication goes. When you give it, we're given the antibiotic, it goes into the blood system and it hops on an albumin, a protein, and then it's carried around to fight infection. So you need protein in order to fight infection, bottom line. So what happens with nephrotic syndrome? You're urinating, but you're urinating all the protein out. This happens a lot with boys and that 2 to 7 range. What happens is when all the protein is out of the intravascular space, it takes fluid and it goes into the interstitial area. So there is edema generalized everywhere. And again, weight gain. So against that question, this is one of the things I thought of. Another thing is poor appetite. Their mouths, their gums get all swollen, and then they bite them, and then it's painful, so they stop eating. In the case of nephrotic syndrome, even with this extra swelling and fluid, usually their blood pressure is normal. So, what would you see? This urinalysis, we would see a lot of protein and maybe some red blood cells in there. And the other thing we have to be concerned about is these children are at risk for infection. So we need to make sure we wash their hands and make sure that they are, we're keeping them as clean as we possibly can. Now, nephrotic syndrome treatment is actually steroids. It reduces the proteinuria and edema in this case, believe it or not. But remember, they are immunosuppressed. They are children that are more apt to get infections. So remember, steroids mask that. So you have to look, you have to be seeing what's going on. And it could be that fever that you might see. Again, that medicine toxicity. Remember, I told you not enough protein. Now, medication can't jump on a protein. It's going to be free drug in the blood supply. And that free in the blood is going to cause increased levels, and it can cause very easily toxicity. We don't give diuretics. It doesn't work in this case. Other swelling, due to congestive heart failure, yeah, all that extra fluid, your diuretics will work. In this case, no. Actually, what they do is they give IV protein, albumin, and that goes into the blood system and it pulls out the fluid from the interstitial space and then they urinate it. So that's the big thing about nephrotic syndrome. So this is something to do with fluid balance, right? This has to do with fluid balance and being more apt and prone to get infections. So they need to do daily weights and keep an accurate level of it, okay? They also need strict intake output and some of the immunizations, like live vaccines, during times in their nephrotic syndrome when their T cells are lower and they're more apt, they're not going to give live vaccines. Usually, the families, it doesn't matter. Now, what is one of the conditions that is caused by a strep throat? A, group B, beta-lytic strep infection. Rheumatic fever, that's the first one we heard about, with the heart, where everything's there and it causes mitral valve damage that cannot be repaired. Well, another problem caused by strep is a glomerular nephritis, and it's called an acute glomerular nephritis. So what happens is this child, all of these antibodies in there tend to go into the kidneys and attack it, and what it says is stop working. So what we need to do, the antibodies are from the strep. So we need to treat the strep. Again, rheumatic fever, you give your antibiotics to treat strep. Acute glomerulonephritis, also give long-term antibiotics to fight the strep. They're the same sort of concept here, okay? One attacks the heart, one attacks the kidneys. Usually, if caught quick enough, we'll give them the strep and they'll be fine. It can go a while longer though. Well, you have an 11-year-old girl has been diagnosed with a urinary tract infection. What key point should the nurse teach the patient and her parents about treatment of the condition? What's the number one thing they should be taught that they have to be aware of when you are apt and prone to get urinary tract infections? It's fluid. It's increasing oral intake, right? Keep those kidneys flushing. And then, of course, 11, don't ever assume they're not sexually active, okay? Because it could be. I've seen 9-year-olds with babies that, I mean, yes, that's very young, but I've seen it. Um, also, are they wiping front to back? I mean, this could be a child, 11, they're already menstruating and, maybe they don't change themselves frequently enough. I mean, there's so many things like that. You got to think of 11, what might be going on? What's keeping that area dirty? 11-year-olds should know how to wipe front to back. An 11-year-old needs to know to urinate when they have the feeling and not to hold it. But what's those other things? So that's what I think about. Now, Wilms tumor is an adenosarcoma. It's on the kidneys. Okay. What is interesting about it? It's also called a nephroblastoma. Usually, males, African American, about age 3, we find it. Very difficult to find because it's a tumor in the abdomen. And usually it's quite large when we find it because, they're urinating, everything looks good. They've got this big mass. Um, I had a boy during that Haitian earthquake a while ago. Our hospital went down to do some volunteer work to help him during it. And they found this little 3-year-old boy with a Wilms tumor. And they got in a religious group to get them here to the airport. They picked him up and brought him directly to my hospital. And I said, "So why is he here?" And they go, "I don't know. They just said to come get him and bring him here. Here's the records." Well, the records were in French. So I knew a little French, but not that much French. So I had to do an assessment. I really had to look. The kid didn't look bad, didn't look like he was in a lot of pain. He looked scared. So I had to get on his level. I had to build a trust up, and I was able to do a complete assessment. And when I touched his abdomen on that left lower quadrant, I found a softball size tumor, a lump, a ball. And for some reason, I knew that it was a Wilms tumor. The thing about a Wilms tumor is that when we tend to manipulate them, little pieces fall off, and that is a metastasis. And one of the things that you're going to put a sign on the chart, sign over the head, on the bed, wherever it needs to go, don't palpate the abdomen. And as we're changing diapers, we need to change and be very, very careful with that. Now, it's a kidney problem, a kidney tumor. It can cause hypertension. So does renal failure, right? Kidneys. That's one of the things it could. So they do surgery, radiation, chemo, and they get it out. And these kids actually do really well. And our whole thing is that pre op, as nursing care, don't palpate that abdomen. Now, a hydrocele is extra fluid in the testicles, and it hurts. And the scrotum will swell. They treat it. What you usually find is number one, they're in pain. But what happens is older kids will be incontinent where they haven't been, and then they'll have this pain. And that incontinence is what gets them to seek medical care. They give some antibiotic, like a Rocephin, actually, and they'll do a culture to be sure. And that's how they treat it. Cryptorchidism. This is your testicles. What does the pediatrician do to a male newborn on first visit? They're going to check the scrotum, see if the testicles are there, making sure that they have distended. Males, when it's warm, the testicles will hang because the testicles don't like the warm body, so it pulls away and they hang. If it's cold outside, they suck up and go closer to the body to keep warm. So if you were going to do an examination checking testicles, you want a warm room. That does make sense, doesn't it? Now, sometimes treatment could be hormonal treatment. Sometimes it might need to be surgery. And this is a child that had this problem with testicles coming down. This is one that needs to be adamant doing their testicular exam monthly. Women do breast exams, men should be doing testicular exams. One of the things we can do is that scrotal support. When after they do surgery, sometimes they've got to take it to bring it down, and it gives that support while it's healing. Of course, that suture line is right there by the anus, and anus has could be coli. So being aware. Again, some of these children, if they're younger, won't remember, but if they're older children having surgery on their testicles, they're going to be scared because remember, they're worried about castration, right? Part of that, end of toddler, preschooler age. So, this is that child before surgery. We really need to talk to them about um, they're not going to cut off your private parts. We're just going to make it better. It's going to be okay, because and you've done nothing wrong, all of those things. It's very touchy. That's why I try to get it done as early as we can. So, this is part of this again, talking about that having surgery on their private areas, right? Because right around preschool, 3 to 6 years of age, children are getting very curious. And this is where they start touching themselves, exploring, and masturbating. They don't know what they're doing, but it's all right. I can touch that there. So they're aware of what they look like now. So surgery during this part of development really needs good preparation, really needs that child to understand what they're doing, how they're doing, and that they're not going to take anything off that shouldn't be there because they're scared and they didn't even know to express that to you. So during routine monitoring, a 6-year-old boy underwent renal surgery 24 hours earlier. The nurse noticed a temperature of 1025. What should the nurse suspect and what interventions are appropriate? We have renal surgery. We're going to have some sort of urine problem there. There's an infection. Is there an incision? So, how would we treat it? Well, we're going to call the doctor. Probably we're going to do CBC, a blood culture, start antibiotics, right? Antipyretics take care of it because they're uncomfortable with it too. And that 102 could have been they were getting sick before they come in too. So, we got to think of it. Now, skin conditions. Kids have lumps and bumps and rashes and sores of all different types. The skin protects our whole body. It's the first line of defense, right? The skin protects the insides. It also keeps the water and stuff inside and the bad stuff out. It can burn it, then we'll have to work with it. We know that the skin takes care of itself. You get cut, it's going to heal. You might have a scar, but that's what the integumentary skin does. Now, sometimes a skin condition can tell you something else is going on. Well, remember I talked about things like Kawasaki, and it's a systemic vascularitis. They get a rash all over strawberry tongue and lips, right? So it was a skin condition that I'm describing, but they were specific to your Kawasaki, and that's what this means here. We know skin color is really important to look at. And one of the things we're going to be doing is some allergy testing, trying to eliminate if there's any allergies creating these rashes and whatnot. When we're looking at and assessing, always look at the hair um, because children that don't have proper nutrition, their hair is not going to be as thick and as shiny as it should be. And you will see a difference, okay? We know that there are things that make your hair fall out, change color. So, all of those things we need to keep in mind. Now, when you're documenting, I mean, there's all sorts of stuff here. The size, color, configuration, any pain on it. Is it itchy? Where is it? Just on the face or is it just on the trunk? Is it just where? Very important. All over or one place. And then what do the lesions look like? And how about the skin around them? Is it open? Is it oozy? Now, one of the big things with skin irritations is the itch. Because what do kids do when it itches? They scratch. Children scratch with those dirty nails and the fingers, right? Because Children don't wash their hands as well or as frequent as they should. They're getting better today because of COVID and they're taught in school now. But keep their nails short. And of course, the hand washing is good. Now, preventing the secondary infections, because you can get a skin infection that can go systemic and can make you very ill. So, managing the itching will manage that not getting a secondary infection. Also, skin disorders is keeping it moist, keeping it creamy, oily, keeping it soft. And that does help with many of these skin disorders. Different sort of rashes. We can have the crust, then we have the vesicle, and then we have the macules. And one oozies and juicies, and one is there. So, describing them, macules and papules is usually one of those things that works well. Pustule has pus in it. So knowing, the different types of them, and it's just for the description for your notes. Now, ever see one of those little things in the side of your eye? Oh, and they hurt, don't they? It's called a hordeolum, and it's sty in the eye is the other word we call it, and it is painful. It's on the eyelid somewhere. Could be upper, could be in the bottom, and we just treat it with nice warm heat to bring it to a head. Sometimes they might give you some antibiotic drops for them. Strawberry nevus or a hemangioma. It's a really intense area of blood vessels, and sometimes they go away by themselves, and sometimes just putting hormonal creams on them can take care of it. There's actually a drug. This is crazy because I never understood, but Inderol, propanolol, it's a beta blocker taken by the child can decrease these things. So they look at what's the best thing and then they try to get rid of them. Port wine nevis. This again is just looks like somebody spilled red wine, and that's what it looks like. Okay, it does not disappear. It's it's less dark as it's older, but it will be there. Again, they're working on different ways to decrease it. Cafe au lait is that white and black skin. I think the most famous of this was Michael Jackson, right? Where there's all different, some white, some black, and it's just a part of the skin. So we have hypopigmented places, and then we have, the oval patches on them. Butterfly rash, that's associated with lupus. And it could look like a little rash. It could be red. It could be spots, all different looks, but it's over here, the nose, the whole thing is there. It's very sensitive to sun. It can cause burning. So we got to be very careful with lupus children and the sun and exposure and UV lights. Scalping skin eruptions around the mouth that looks like a big horseshoe shape here and the chin. You can see it perianal. Again, scaling these eruptions, and a lot of times these are rashes with zinc deficiencies. Sometimes it's due to that overabundance of diarrhea, which is causing the skin to break down. A vascular birthmark. It's a bruise. It changes colors over the years, you know, and they will slowly get less and less. They're born with it, and it's a lot brighter. So, a female adolescent has a port wine nevus since early childhood and now has severe acne. She doesn't understand why she's susceptible to these skin disorders and asks whether she's done something wrong. This is not an uncommon thing for a child of any age to ask. So, how would you respond? Like I always say, it's not your fault. Sometimes you have these extra, you have your special mark, it's your special thing. And, as a nurse, I've taken some really not nice looking things and made them less, you know, in the mind of the child, to try to make them feel that they were that feeling of inferiority shouldn't be, and children get that and they're not going to want to move forward. So I would say I think you just got a special mark that you were just kissed by whatever your God name is, if that's what you want. Left a lipstick stain there, multiple kisses by the angels, whatever you want to say. Those are better than, ignoring it, but never make a child feel it's their fault. Now, infectious miliaria, this is prickly heat, right? Usually it's in a diaper, it's hot underneath the chin, in the neck. It gets overly wet, it breaks down. The sweat glands and hair follicles, they get clogged and then it creates all of this and it becomes infected, okay? It'd be tiny and then it gets bigger, more like pimply looking. It can be itchy. As I said, a lot of times it could be in that diaper area and those skin folds. And underneath the neck is the big one, especially on infants. So, what they say is the kid is having this, take off their diapers and just let them be, bare butt on their tummies on tummy time, right? Put a diaper underneath them or something to catch if they have urine or stool. But it really will help with the treatment. Intertriego, chafing. I mean, I think as a woman, a large woman, I always chafe between my legs, right? Underneath the dress. Well, where do children chafe? Again, number one, it's that neck, it's that no neck syndrome. And then their pudgy legs, and it's always, rubbing and chafing. It's that dermatitis. We know an overweight or larger sized child is going to be more prone than one that is not. The goal is to try to keep it clean and dry. Seborrheic dermatitis, cradle cap. Children are born with this, and mothers are like, oh my God, what can I do? I want to get rid of it. They want to put a cute little bow ribbon on their head, right? And with a head like this, they don't want to draw attention to it. So, what do we do with it? Well, cradle cap is all different colors. It's all different thicknesses. Um, Mostly we see these in newborns and infants. Sometimes it's a change of puberty. Sometimes we see the eczema, stuff like that. But what we do is we'll shampoo it normally. We will sometimes put olive oil at night and then we'll just take a fine comb very easily, gently. We'll brush it, and then we can shampoo the olive oil out in the morning or whatever oil the doctor wants. But olive oil works great. Diaper dermatitis. The one thing about diaper dermatitis is you have to wear a diaper. And the time that it's the hardest to work with is at night. You take the baby and you bathe them and they're dry and they're good and you put a nice dry diaper on them, put them to bed, and then they stool, have urine, and now they're awake crying because it's red and it hurts. Baby loses sleep, you lose sleep. So how do we do things? Well, I actually found in my household, everybody was allergic to Pampers. Put it on one day and they would be all red front to back. Any other diaper, in fact, the cheap store brands, the grocery store brand was actually the best on them. But it could be that. It could be the soap. It could be the creams, the lotions. It could be the wipes that you use. So many things could cause it. So you have to try to take everything away and perfumes out of everything, even washing the clothes like that. So sometimes rashes are due to contact, like diapers. Sometimes they're due to the foods. So at 6 months old, we're introducing foods. You'd be checking the diaper, see if there's a rash in there, because that's what could be causing it, the food that you gave them. All right. Now, sometimes they get these little dots on them and it looks beefy red. That could be yeast or candida. And that's nystatin. There's creams and there's powders we put on them. And the goal with diaper dermatitis and curing it, taking it off, let it air during the day when you can, but to clean well and to change diapers frequently. That will keep that urine and the stool off and the irritation. Acne vulgaris. This is those big sebaceous follicles. We see a lot of this start with all the hormone changes at puberty, right? And it's just because they're secreting more of sebum, which is like a fat substance. Comedo is keratin or a bacteria. This is blackheads, whiteheads, and again, pimples that you would, the adolescents will be squeezing them to get rid of them. How do we treat it? Well, routine cleaning, but not over cleaning. Over cleaning can generate more oils. So we got to be careful. There's a fine line. Also, avoiding products that can exacerbate that, like anything with grease and oils. We wouldn't want that. And then using, they've got so many products out today that actually work really well. And you can find all different price tags on them from not too much to quite a bit. So, one of the things with acne, since it has to do with the adolescent, they need to be in charge of their care. So make sure that
By me, that shit does it all the
Ariana,
time.
could you put you on mute, please? Miss Norad. Again, let's hope it stays there. Anyway, so have an adolescent be in charge of their treatment, not to overdo it, and explain those reasons too. You'll have some adolescents who'll do it 6 times a day just to get rid of this acne. No, that's not the way it should be done. So doing it accordingly. Now, herpes simplex type 1, this is the cold sore, right? Children can get it everywhere and it can spread. Have you ever had a cold sore? It hurts, it burns, and it's oozy and it's juicy and it's very uncomfortable. When you look at this kid, it's up around the eyes and the mouth, up in the nose. So it's something that what we do is give antiviral medications. This child, because it's so all over, would get the oral antivirals, right? And they also would be like acyclovir and then maybe some creams and lotions on the mouth. Infantile eczema, kids that have an atopic dermatitis, and it could be anywhere and all over. So it can be treated, but again, we're going to be treating it, keeping the nails short. We're going to be keeping it clean, not over clean, putting the creams and lotions as we should. And hopefully, it'll slow down like this little child here. Now, spongiosis is the breakdown of these cells and it forms these
I heard it's
vesicles.
because. And that's it. Oh, there it is. One knife. Like,
So rarely do we see infantile eczema in infants that are breastfed. They've just getting mom's immune system, so it does help. Sometimes they take breast milk and put it on them. Actually, that is a healing for many different things. Um, Worse in the winter because they're covered up more and it's more dry heat out there. And because it's any sort of irritation, any of those can turn into a bacterial type of infection. So, one of the things children that have eczema shouldn't be around adults or other children with cold sores because they can respond to it and it can cause them to catch it and then get worse. Also, because they're sort of immunosensitive after immunizations, these children probably are going to have the fevers and the swollen leg, red, and get to treat it with heat and then bicycling their legs to get it moving around. And of course, we're looking at their immune system. So infantile eczema, again, always trying to relieve the itching, always keeping it hydrated, and also preventing infections. nice emollient bath. They've got all different sort of baths today. Oatmeal baths. You don't have to get the fancy stuff. There's really just good stuff in your cabinet in the kitchen. Look at that cornstarch, baking soda. All those things work really well. You don't have to do the big Aveeno baths and whatnot. If you have oatmeal, use oatmeal, and it does work. Bath oils keeps them moist, and it keeps the moisture in. If it's inflamed, if it's itchy, corticosteroids. Steroids decrease inflammation. Also, antibiotics for those infections, and of course, stuff to stop the itch. So, what they say with these children with these skin conditions, make sure that we wash off all the old stuff or wipe off all the old stuff before putting on the new. Remember, you can overdose on creams and ointments, okay? Cortisone creams, they're avoided, right? And the reason is twofold. Cortisone masks the infection. And number two, it's absorbed in the body and they're getting a big dose of prednisone, which can really have long term effects. Medications, they're best after that warm bath. Their pores are open, ready to accept it. Always apply with stroking at the way that the hair grows. And more does not make it better. I always describe that. Less is best, more doesn't make it better, okay? And sometimes infants, if it's all over their head, or even that child that was having the herpes on the face, elbow restraints keeps them from getting there, itching it and spreading it. And as I said, steroids shouldn't be used, and most of them are not, even with viral type of infections. Now, staph. We've talked a lot about strep. Let's talk about some staph. Now, one of the most common infections is a staph infection. We see it in the umbilicus or after a circumcision. These are open areas that aren't really paid attention to as maybe as closely as they should. Once you have staph in an area, it can go into the bloodstream and then it goes systemic, and that's septicemia. If you have an infant that has like a little rash that has pustules with pus in them that can burst, this is something that's probably staph. We need to tell the doctor so we can treat it. Antibiotic ointments are used for small places, but IV antibiotics are the ones that are going to kick it out and not let that staph go systemic. MRSA is methyl resistant staph aureus. This is the one that's hospital acquired, right? This you need to do extra special precautions. These children will be placed in contact isolation in a room by themselves. Now, there's something called scalded skin syndrome. And if you look at the picture of A, you can see how just like blisters, it's pulling up. That's what would happen if you got sprayed with hot water, it would bubble up, right? So that's what this child looks like. Usually, these kids, we'll treat them, keep them dry and clean, prevent infections. They usually heal with no scarring, which is, remarkable for the amount of skin that looks this way. Now, impetigo is another staph infection. Christian came over to my house, my grandson, and mom said that he had scratched behind his knee a mosquito bite so much that now it was getting bigger and now it had a scab and it was juicy. I looked at it and said, this is impetigo, which is staph. So I treated it. I had the antibiotic ointment here that was good and treated it. And we had to call the doctor and get oral antibiotics too. Highly, highly contagious. It can spread. So again, they need oral, parenteral, or topical, or all of them, depending on it. Fungal infections, you hear of ringworm, right? And you think of a worm, but it's a fungus infection. So fungi, again, we pull it around by our hands, our nail that helps it go around. We have tinea capitis, and that has to do with alopecia, no hair. It could be in the hair. Tinea corpus, again, this is an oval, scary looking ring of things. Again, looks like that roundworm thing. Tinea pedis. Well, isn't that foot fungus? That's your feet. So again, treating that, and then there is that adolescent who or young or the older school age that are in sports and they wear a jock strap to protect themselves and it sweats in there and sometimes they don't clean it every time they forget they wear it again and then they get this tinea cruis which is a fungus in their peritoneal area. Pediculosis, we have head lice, body lice, and pubic lice. Um, it is a little type of animal, insect, bug, very tiny. They hook into the scalp and they suck blood out of you. And they lay eggs. And if you look at that top picture, it's a great picture. The little tiny little white balls are eggs, and the other ones are the animals. This is something my daughter has thick hair, thicker than mine, down to her buttocks, and she had head lice 3 times as a kindergartner. You know what it is to go through and have to comb her hair all that time. And then also, you have to do all the sheets, the blankets, the whatever's in the house, wash everything. But we did it. She lived through it. I didn't have to cut her hair. I didn't want to. Scabies is parasitic. It goes, these little things go underneath the skin and it causes intense itching. And they put their eggs and their feces and go underneath, and they're in these hot spots in the folds in the body. And these need to be treated with a medication called permethrin. And if one person in the house has scabies, treat everybody because everybody has it. So a mother comes to the clinic with her 1-year-old child. She has visible infantile eczema on her face. She remarks that she can't have this picture taken because of the visible lesions and asks how long will they last or what she can do to eliminate them. What would be an appropriate nursing response to her concerns? When do you think they would go away? Infantile eczema. Do you really have an answer for it? Some heal quicker than the others. I wouldn't really have a total answer. Burns, very common. Kids like to go to the stove and pull down a pot on the handle, right? Or go in and grab mommy's curling iron and now they're burnt there. I mean, it happens all the time. Picking up, being outside around fires and barbecues and whatever it is. It's taking electrical cords and putting them in their mouth and biting on them and then getting electrical burns in the mouth. I mean, there's all different ways kids get this. And it's not always neglect. Sometimes it is. Sometimes it's abuse. But most of the time, the parents need to be taught how to keep things away from their children and to be aware of it and, that what can happen with it. In burns, we need fluid resuscitation, we need pain control, and we need to worry about all of that creams and lotions and dressing changes. So these are all the areas and how much they numbers you would put into the resus of fluid on these children. Depending on where it is, how much fluid are you going to get? And there is that burn guesstimation table. Now, your exam doesn't have exact numbers on this. It's just knowing burns and fluid resuscitation, right? Fluid resuscitation is one of the important things. We know it can go from very mild to very deep burns. Um, Remember, any burns around the face, always be concerned of oral airway. May might have inhaled it there. So airway is always important. So children, their skin is thinner, so they get more serious burns and it goes deeper quicker and for shorter amount of times the exposure. We know that children don't respond as quick as older. Their reflexes aren't there, so they'll be burnt deeper and harder. And we know any burn does result in fluid electrolyte and heat loss. So if it's more area, it's more area that has greater fluid electrolyte and heat loss. So sunburn, I live in South Florida, and it's one thing that we really have to be and pay attention to. We know that skin can be injured and it can be to just to be sunburned, okay? So our goal is to keep um, good suntan lotion on them, to reapply it and to have them in there in the sun not too long of a time. Get them under some sort of shade. So the goal is to stop the exposure with suntan, with sunburn, treat inflammation, rehydrate skin. I mean, we all have had our um, home remedies for sunburns. My home remedy was that my father gave us. It was using vinegar and putting it on us. And I just think it was the cool liquid that pulled the heat out. But he used to take us, and there was 7 of us. I had 6 brothers. We'd come back from going to the lake because I lived in very rural New York, and we would all be lined up. We would all get vinegar poured on us. I had to share that. Frostbite. Frostbite is real, and it's because an area gets cold and doesn't warm up quick enough. So chilblain is a cold injury, and it happens now. You get erythema redness, you get vesicles, you get all this vasoconstriction. Your body area there is dying underneath there. It's extreme cold, and it has, basically had the tissue dead. And now you're going to see the results of that. When we look at it, we can see that there's a color, that deep purple there. You're going to see more sensation. It'll turn black almost. And then you hopefully see it sort of perk up as we slowly warm these children. But again, as I said, they're frostbit too long. They're going to lose fingers, toes, feet, hands, depending. So a school nurse for an elementary school must prepare an educational program for the school children on emergency responses for a burn injury. How would you treat a burn? What would you do? Your child got a burn. What would you do?
Rain a cool water on it.
As simple as that. Yes, Awa, as simple as that. Um, I have an example of, I was always the nurse on duty with me and my friends' children. I had a friend who had 5 kids, and on 4th of July, it was one of her daughter's birthday, and we'd be there, normal place, and we'd watch the fireworks go off, and then we'd have a couple little ones for the kid. And we'd be there all day long at the pool, and we'd have a cooler with ice in it, waiting for 9 o'clock at night when fireworks would go off. And I'd be sitting right next to it. And there would always be one kid dropped a sparkler in between their toes or got sparks on them. I mean, we never gave them big fireworks, but I remember one day this girl, little Katie Bird as we called her, had a sparkler, fell between her toes, and it burned in there. She come running to me because when they got hurt, it was always to me. And I took her foot and just put it right into the ice bucket just to pull out all of the heat. And it did stop the burning, and that was the goal. So, metabolic conditions. When you think of metabolic, it's all the endocrine system. And we know the endocrine system, it does control the nervous system. We have the endocrine system. And we know if the endocrine system isn't giving what you want, neurologically, the child's not going to be there, as in hypothyroidism in the infant. You don't get, and that's an endocrine system, the thyroid. Don't have enough thyroid hormones, they're not going to grow, and cognitively, they're going to be delayed. So, endocrine system things you might see: lethargy, poor feeding, failure to thrive, vomiting, enlarged liver. That could be something. It's telling you something that's going on. you know, then it goes on about unexplained mental retardation. See, this is where growth and development, knowing they should be lifting their head by 3 months and they should be doing voluntary grasp by certain, they're not. Something's going on and it needs an investigation. Sometimes it's as simple as hypothyroidism, right? And we want to make sure we replace that hormone so that we can give them a chance of normal cognition. Sometimes we get all of the signs, and they're showing us those little things. We're going to be doing an x-ray. Maybe it's something going on, other things that's happening. We're getting that PKU test, really tells us metabolic screens and intolerance to foods. Looking at chromosomes, is it a Down's child, right? Those things will tell us a lot of stuff. Tissue biopsies, looking at thyroid function, absolutely. And looking at ultrasounds, seeing is everything, in the size and shapes that it should be. And a 24-hour urine's telling us electrolytes. What's going on there? Are they where they should be? Now, there is something called liposomal beta hexosaminidase. It's an enzyme. And all that does is it takes fat in your body and breaks it down to use, like bile does with food. This is another thing. And the thing is, in this case, lipid deposits aren't used properly, and it deposits itself on nerve cells, brain. And when it does that, it stops the synapsing the way it should, and it causes physical and mental deterioration, retardation will happen with it. Tay Sachs, fat. And it has to do with the Ashkenazi Jewish population. And it is passed along, it is a trait. So what you see is the physical development isn't doing what it's supposed to do. You can see here head lag or inability to sit. They should be able to lift their head up by 3 months easily. They should be able to sit unsupported by 8 months. They're not. That's when we start really looking. And then it goes into, because fat accumulates in the eyes, in the brain, so blind and mental retardation. And it's not any treatment we can do with it. It's just, palliative at this point, and then just trying not to, to limit the fat in these children and to find out before they're born that this is going on. So hypothyroidism, most common of all of them, it can be congenital or acquired. We know in congenital, the baby's born and the thyroid gland is not functioning the way it should. As I said, we know sometimes that because of the developmental things, they're not growing, they're not cognitively aware where they should be. Now, one of the acquired one that we see later on, usually girls, late school age and adolescents, these children have lymphocytic thyroiditis. It's called Hashimoto's. This is an autoimmune. You cannot remove the thyroid, it has to stay. But what you must do is give thyroid medication replacement. And they really need to watch those levels really, really fast. So, one of the things that we do see. So, one of the things that they do now, and they didn't years ago, is a mandatory test of thyroid. So we're doing thyroid hormones. If we're seeing a kid is tired, sluggish, all the signs and symptoms of hypothyroidism, they're dry, they're cold, then of course physically they're floppy, they don't have control the way they should. It's the cold intolerance, it's the constipation, it's the dry skin, brittle. These things are those little signs and symptoms of hypothyroidism. And as I said, if we don't treat it and we don't give back that hormone, that child's going to have irreversible mental retardation. So we're going to give hormones. Now, when do you give thyroid hormones to anybody? Do we give it in the morning? Do we give it at night?
In the morning.
We give it in
In
the
the
morning
morning. Yeah. And they say
because
usually 30 minutes, or for me, it's 30 minutes to an hour before I eat.
and the reason why it's the morning because it
Now
picks you up.
fucking unplug my charger for a second. Now
Okay. So
Uh-oh.
we usually do it in the morning because it speeds you up. It gives you a boost. You think of getting your thyroid, you're going to get your energy. We don't give it at night because you're not going to sleep. And it's absolutely, Christian, before they eat, immediately before they eat, first thing in the morning, same time every day.
I
We
didn't know
know
how
that.
oh, I'm sorry.
Go
I'm
ahead,
sorry.
Christian.
I'm sorry. I didn't know, since we on this subject, I hate hypothyroidism, by the way, because I have it. Came out of nowhere. I didn't know how common it was. And then my doctor was saying that sometimes it can like be dormant or something. It's like a lot of people, like especially women, we end up getting diagnosed with it like after a kid or two. And I just hate the everything that comes with it. And I didn't know, because I used to didn't take my medicine just a second, um, that how much damage it can do when your levels are not where they're supposed to be and
And
everything.
emotionally, you're all over the place.
I didn't know that you can be depressed, like so that
There you
yeah,
go.
like you,
Absolutely.
it's
There's
like when
so
you're on your
much.
cycle.
There's so much with it that people don't understand. Cold intolerance, constipation, dry, brittle
The
hair.
fatigue is real bad.
Oh, fatigue. Absolutely. Yep, I understand it completely. So, too much thyroid. Now, we have hyperthyroidism, and then we have taking too much medicine. Sometimes, let's say you forget that you took your medicine, you take it again. You can have too much replacement. It acts just like too much thyroid hormone normally of hyperthyroidism. Everything speeds up. Heart rate, you get tightness in the chest, so you get dyspneic, you get irritable because you don't know what to do with yourself, you've got weight loss, and you're sweating. Those are when you're taking, let's say you take an extra dose and you don't know that you've done it, or maybe they prescribed you too high of a dose and it needs to be decreased. These are things to look out for. It's like a thyroid storm type stuff. So something to be aware of. And then too little is like you said, fatigue, sleepiness, and constipation. You're tired, you don't understand, and if you have a child like this, parents need to know what's going on and the things to look for. Now, there's diabetes insipidus, and then there's syndrome of inappropriate antidiuretic hormone, which means in your pituitary gland, the posterior side, there is a gland that produces something called vasopressin. And what it is, it's an antidiuretic hormone. And what it does, it regulates fluid balance in your body. So, diabetes insipidus is when all of a sudden, and it could be intermittently, you are what we call the two P's. You're polyuria and polydipsia. You're thirsty, 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 and you urinate, 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 urinate. And the body doesn't know to stop, and it just keeps it up. Now, how do we stop that from going on? It's the antidiuretic hormone, vasopressin. Now, the complete opposite of it is the syndrome of antidiuretic hormone. You see it on the bottom in the middle, SIADH. Whereas diabetes insipidus, you urinate and you drink. Syndrome of inappropriate anti against urinating hormone, you don't urinate. So now you're getting full of fluid. So DI, you're urinating, urinating. In SIADH, you're retaining all of that fluid. We have a parathyroid. Parathyroid basically monitors and regulates calcium in the body. And calcium is all about muscles and muscle strength. Too little, too much. Too little, you're weak. Too much, you're just so tense because you can't move. You're so tense the muscles. So parathyroid, it's not a thyroid, it's calcium. Now, adrenal has everything to do with steroids. Steroids, we know, they can say the adrenal is all about your steroids and aldosterone. And usually, when we talk about too much adrenal, it's that we have given too much steroids for too long of a time, usually. I mean, sometimes, yes, you have a tumor, but I'm telling you, most of the time it's you've been put on prednisone too long. And then you go into Cushing syndrome, which you know, big moon face and the ruddy cheeks and hair and acne. And this happens with that. Now, diabetes mellitus is all about when the body's pancreas doesn't have the insulin to be able to take the carbohydrates in the body and put them into a usable substance. So, what happens is the body can't use carbohydrates, but you know, the body is still hungry, right? So, what it does, it says, all right, so I can't get carbohydrates from you and I can't eat from that. So then it starts to go and it eats proteins and fats. So that's the basic concept of diabetes mellitus. And it goes from type 1, insulin dependent, type 2, where you can take oral and diet. And then there's the DKA, which is your emergent that you really have to seek a medical treatment. Now, with a child, they say the fasting blood glucose is 126 milligrams. Now, in adults, it's 100. So there is differences. Also, the hemoglobin A1C, they say can go to 7 on a child, but it's 6 at the pre-diabetic in adults. So that's the differences there. So when we have that body can't get the sugar, the insulin's not working, we're going into DKA, they're eating fats, they're eating proteins, and the byproduct of fat and protein digestion is ketonuria. So what happens is we start to spill all of those ketones out of there. Now, if we have a child on diabetes and blood sugars are not managed, we're not getting nutrition. Again, that's first of all the bottom line, nutrition. So they're not going to be growing the way that they should. Also, what happens when you have blood sugars high for long periods of time? Blindness is one of them. Circulatory problems, peripheral neuropathies, kidney disease. I have some young teenage girls that used to come in DKA, and not once a year, multiple times. And I'm like, how many times do I have to tell you? Do you realize that you have beautiful eyes? And if you don't take care of your blood sugar and watch it with doing your blood glucose and giving yourself your insulin, you're going to become blind. And sometimes that helps them. Now, do you know what I have told young adolescent boys about their diabetes and if they don't treat it? I'm like, you're an adolescent. Do you realize there's peripheral neuropathies that can occur where your nerves don't work? And this can happen with your penis. And it can cause it not to work. Now, how do we treat diabetes? I said, eat right, take your insulin, monitor your blood glucoses, and we can prevent these things from happening. And sometimes telling them like that, they'll listen to you. So I've already gone over the type of diabetes. The one thing I didn't mention was gestational. Gestational is when you're pregnant and you become diabetic. You cannot take oral medication during pregnancy. It must be insulin. One of the things that they do say is that they might turn into type 2 diabetes a little bit later on in life. It's one of those pre-skewers of, so if you're gestational diabetic, you had that, it's probably going to be diabetes later on in your life. So diabetes type 1 is the three P's: polydipsia, polyuria, polyphagia. Diabetes insipidus is polyuria and polydipsia. That means thirsty and urinating. This is diabetes insipidus. Has nothing to do with blood sugar. It's only blood volume. Fluid. Diabetes type 1, any diabetes is three things. Polydipsia, I'm hungry because I'm not digesting carbohydrates. My body's still saying I'm hungry. And of course, I'm urinating and also I'm thirsty. So these things are those three symptoms that you will see. You'll see that child all of a sudden start losing weight. You're going to start seeing them get tired and weak, or you might see the skin dry. You might see vaginal yeast infections, but it's that all of a sudden they get tired, weak, lethargic, and they lose weight, the young kids, and that usually brings them to the doctor and they find it. Glucose in the urine is called glyceria. And hyperglycemia is when the glucose cannot be used. So it's floating around in the blood. And hyperglycemia, just like earlier, is greater than 126. You'll see that. I've seen in DKA one child with a blood sugar over 1,000. That was the biggest I've seen. The child's pH was 6.898. That is like almost death. And we did get this kid awake and alert out of the ER upstairs to the intensive care. It was a very scary situation. He was so young. It's like 7, 8. It was young with those sort of numbers coming in. So when you can't eat your sugar, protein and fat is for energy. We know that that lack of eating glucose not being available, that's what causes the polyphagia, makes you eat more, right? It gives you that polyphagia, I'm hungry, hungry, I want to eat. But it doesn't matter. The sugar's still not being used. Random blood glucoses, we do these at no time. It's whenever. Fasting is usually in the morning. I've already told you it's 126. And they say it has to be at least twice before they even consider diabetes. Glucose tolerance, if you've ever been pregnant, you've all had that glucose tolerance test, right? Swallow that sweet syrup. But they also do these for children that they're concerned about. But what they're looking at is the blood levels and how long does it take to come down. Now, glycosated hemoglobin, hemoglobin A1C. So 6 to 9% is actually good control on a child. We know that we want our adults below 6, but 6 to 9 is for children. They give them more sugar and they say values of 12 is poor control. So I'm going to keep going through these. So diabetic coma. What happens is sometimes they are sick also. And then we know that the body's not eating carbohydrates and they're eating proteins and fats and they're having ketonuria going on. And then they have this infection. And then, of course, it'll go on to ketoacidosis. So, what do you see with DKA? Well, you're eating fats and proteins, ketonuria. You're going to have a decreased serum bicarb, which means your pH, instead of being 7.35, 7.45, it's going to be lower. And I usually have seen them less than 7, which is quite scary to me. They're going to be dehydrated because they're losing fluid, right? Polyuria. They're going to be nauseous because they're hungry. They want to eat. And then they start getting confused, that altered level of consciousness. It can happen quick. It can happen over a bunch of days. We can correct it quick, but it's that maintenance of it. So we need diet. We need insulin given when it's supposed to. And these kids need to be active. They just because they have diabetes, they don't have to be put in the bed.
Go
They
get them.
out doing normal things. Now, these children will need to have, if they're exercising, they're also going to be needing having snacks to make sure that they keep their blood sugars up, right? Because they're burning it with exercise. Education, remember, we have to bring in, sometimes it's diets, it's patients, cultural, religious. We need to think about those things. You know, the one thing that I don't think you thought about is there's some religions that don't eat pork. Do you realize there are pork-based insulins? There's pork-based and beef-based. So knowing what you're giving your patient. So pancreas not working, blood glucose. We need for them to monitor it. They need to know their diet and they need to know the glycemic index. They can make up their own meals and schedules. What does this stuff do? They need to understand this to be able to take care of themselves because eventually they're going to grow up to be adults and they'll still be type 1 diabetic. Once they are, they do not change. What do infections do to anything? I mean, it's going to create probably the need for more insulin or need for more sugar. So knowing stress, emotional upsets, all of these things, we need to know how to treat and what to look for. What if their child is traveling? How are they going to bring their insulin to places? You know, that needs to be, most of them, refrigerated. So you're going to take one of those little um, food bags and put one of those little ice things in it, right? To keep it, and then get somewhere and get it right into a refrigerator. And if you're out, you need to know on vacation where is, in case something happens to your child, where can you go? Where's a hospital? Where's a clinic? Where is something? So nutrition. You're not getting sugars, and we need to make sure that we also promote as much good nutrition so they're going to grow and develop the way that they should. Um, you know, every child's different and every child eats different foods. There's some children that absolutely love salads and there's other children who don't. There are some cultures that have to have this, whatever, in the diet, and it's something that can be worked in. So it all has to be taken into consideration, okay? Remember, as we are sending them to the grocery stores now, reading labels, we have a lot of that food that says dietetic, right? Well, dietetic always is not dietetic. You got to be careful. Some of them are really high in carbs or fat or something. Fiber, soluble fiber can reduce blood glucose levels. So it's something that we should tell them that if we are getting fiber, maybe our glucose levels might be low. They might need a little something. Also, fiber helps with serum cholesterol. And as I said, reduces insulin. So giving insulin, well, we know we have to give it in all different sites. You have to move it around. It's on a 45-degree angle. It's a tiny needle, tiny syringe. Many times today, we have those good little pumps that we just pump it in, right? That's the easiest thing to use, but they're expensive. Not everybody can afford them. They're not always completely covered by your insurances. That's a big thing. I've seen young kids, 6 and 7, doing their own blood sugars. Coming into the triage, I'd say, will you do your blood sugar for me? And I'd watch them do it. Also, there are insulin pumps. Kids about 7 also, they're understanding enough, they can have an insulin pump and they can regulate their insulin administered. And they just take one needle, they put this pump, this little tubing, this little machine on. It's only one stick. And I have heard through some type 1 diabetics who actually been my students, they only change the needle once a week, as long as it's clean, etc., and no problems with it. Then the pump is a great thing. Clear before cloudy. You know that one. Have you heard that? Clear, insulin before cloudy. Have you heard that in fundamentals? And that's what an insulin pump looks like very easily. It's a little tiny little needle with a little tubing in the machine. You can give boluses off the machine. It's a continuous slow infusion and it works so well. Again, it's getting insurances to approve it, for these children, so that they're getting less shots. And, they right there's their insulin. They just pump it in as they want it. Insulin shock is too much insulin and not enough sugar. So it's hypoglycemia. So why does that happen? Well, if you don't eat enough and you took your insulin, or if you're exercising, burning off calories and don't have a snack there to replace it, sometimes it's giving yourself wrong insulins in wrong syringes. All of those things can happen. It's just part of that, wondering, part of figuring out how to take care of yourself with it. Because, these things are going to happen. But as nurses, we need to let them know signs and symptoms of hypoglycemia, right? We see it, they need to do something. Get yourself a glass of orange juice, a glass of milk, something. And remember, kids are more prone to insulin reactions because they're growing and their activities are not planned, they're sporadic. The kid next door comes, they come on, we're playing a ball game, come, let's play with us. Boom, they're gone. Adults don't do that. So, what is it? Hypoglycemia, irritable, they start not behaving right, they're getting pale, they're hungry, they get sweaty, they get jerky, they can get even confused, all of these things with it. So, they need something, some sort of sugar. As I said, orange juice is a great thing. A sugar package, hard candy. There is these little sugar tablets that you can buy commercially that you can take. But there's so many things around. Even milk is what they say they can use. Now, glucagon is something that many young kids they do carry. If they become unconscious, they need something to get their blood sugar up quick. So they do give glucagon. The one thing about glucagon, make sure they're turned on their side after you give it because they will vomit. Always. Now, Samoji phenomenon is this rebound. So you're in chronic insulin use and you have hypoglycemia during the night and then high levels in the morning. This is what it looks like. They may need less insulin to cure this, believe it or not, because we want more of a continuous insulin level. This is what we want. Now, dawn phenomenon is with early morning elevations without any hypoglycemia at all. So these are two words. It has to do with diabetes type 1 in children, and it's that instability that you do see. Type 2 is usually the older, always that's the one who's obese, low physical activity, and they're eating high fat type of foods and It's creating the body not to absorb and take in their sugar the way that they should. So a 10-year-old boy has been diagnosed with type 1. What should the nurse recommend that he do to learn about his condition? Where's information about this? There's so much out here today. You have school nurses. You have, of course, your regular doctors. We have the internet today, right? And there's how many organizations that work with juvenile diabetes, and they do work together. I know of the hospital I worked at, there is a parent diabetic group where they get together and talk about their kids. So this child has a lot of things they can. So let's go into the last part of it, all about different things. So, communicable disease, this is almost on the side of community, if you think about it, that this what this is talking about. Communicable disease is something that I can give to you and you can give to me. Incubation period is the time between exposure and when the clinical symptoms appear. I talk about that one in prodromal, talk about that with chickenpox, because there's a time where I've been exposed and I don't show anything. And that prodromal is that earliest symptom or the appearance of the rash, okay? So that's how I remember them. Vector is the insect or animal that carries and spreads diseases. Think about ticks, right? Ticks carry things around, gives us diseases. Pandemic, isn't that H1N1 influenza? How about COVID? That is pandemic. Now, epidemic is in an area. It could be in South Florida. It could be an area in South Florida that all of a sudden had meningitis, had pertussis, had something. That is an area. An opportunist infection is caused by an organism normally present in the environment that immunosuppressed people cannot fight. Ever hear of PCP pneumonia? Well, that pneumonia is opportunistic. It's here. We all are breathing these, but only that HIV person, opportunistic, is going to get it. And healthcare associated infection is something that comes from the hospital. And as I said, one of those is MRSA, and there's VRE, and there's a couple different more. And it's because we're not washing our hands good enough. Virulence of infection. So, host resistant to disease is influenced by a lot of things. So, will I get all the diseases I see, or will you? It all depends on your age, your sex, genetic makeup, always nutritional status, and your emotional health. Both of those will, your good physical health, your nutrition's good, you'll have less chance of getting some sort of diseases. We have phagocytes in the blood, they're going to kill these things. If we have our skins intact, mucous membranes intact, and our immune system's working. Now, how about me? I have rheumatoid arthritis. Am I more influenced by getting these diseases? Oh, absolutely, because my immune system does not work. Now, types of immunity. This is an important concept here. Natural, you're born with. Acquired, you either got a vaccine or you had the disease and you now have the immunity. Active immunity is when you produce your own immunity against it. Could be at a little upper respiratory and you had this little virus, your body fought it and got rid of it. And then passive immunity provides the antibody to the person. It doesn't last long. That means could be you got influenza vaccine. It doesn't last that long. You're going to have to get another one to follow it. Preventing spread of infection, aseptic technique, standard technique, transmission based. Always know your infection control on your HESIs, on your NCLEX. Infection control is always covered quite a bit, okay? We know that airborne, when we talk about things like TB and varicella, pertussis is another, that we use that N95 mask because it really covers the area. But besides that, any child that you suspect that could have TB, varicella, pertussis, those airborne diseases, that we use that negative pressure room. And what it means is that room is one person in there, and the air in there doesn't return to the hospital. It goes out to the environment through a filter. So it doesn't get spread in the hospital. That's what that means. Contact is all those things that you can touch. Um, CRE, RSV, MRSA, VRE. These are things that these children need to be in their own room. You need to wear contact precautions, gowns, gloves need to be there, and of course, hand washing before and after. Droplet. This is a normal mask that you need to wear, not the N95 one. Um, and the droplets on these ones, they don't stay around for a while. So the chances of you inhaling them are a lot less. So that's why that. Again, it's a mask, a gown, and gloves. And then of course you always take it off and hand hygiene before and after. Hand hygienes, what do you sing? Happy birthday 2 times. Happy birthday to you. And you wash your hands, and we know that's the amount of time. Today we're lucky with COVID. I mean, yeah, COVID was not a good thing. But what it did is it puts those alcohol dispensers everywhere, in the grocery store, in all the bathrooms, in the hospitals, down the hall, in every room. You always have somewhere to clean your hands and keep yourself clean, right? Years ago, we used to wear artificial acrylic nails. Today, no. Tips, wraps, gels, all of that should not be done. They've done research and found underneath the nails of these staph infections. So they should not be using those things. So, how do you teach a family all about these infections and what is going on? Well, we need to wash our hands always. That's the big thing. And the other thing is, really encouraging them to have immunizations. There are some people who don't want immunizations, they've been fed wrong information. And as a nurse, we need to give them documentation and show them, why these things are good. Food storage, big thing. They bring some parents, live. I know my hospital I worked, we had some parents who lived hours away because we were the specialty in whatever they were coming for. And they would bring food with them for the children, making sure they had ice on it, right? Because they can get, sick due to the food spoiling. Using pasteurized milk, I hope we all do. How to cook food, community towels. I bring my towels everywhere because you don't know how they were washed. Insects, the backyard full of fleas and ticks and whatnot, making sure it's sprayed. And they say today, and I used to love my sandbox as a young kid, no more sandboxes because that's where the worms are, that's where disease are, and the kids crawl in it, gets in their nails and their mouth and getting infections. So we mentioned them earlier, but here's some more rashes on the skin. Erythema, diffuse and reddened. Macule, it's circular and reddened. The papule is the same, but it's elevated in the center. And then the pus, the vesicle is reddened area, now it's elevated, and we're seeing fluid in there. And then the pustule is the same thing, but with pus in there. So we know that these are the types of rash we would see. A scab is when they're all dried over, and pathognomic is that term used to describe a lesion or symptom that's characteristic of a specific illness. How about the term cup-lick spots? When you have measles, you might see cup-lick spots. So these are things like, even so, the one on the rash on the face with lupus, that's a lesion that you would see in lupus. And same thing with that name. Healthy people 2030. I never knew what healthy people was when I started back from my bachelor degree. And what it is the government focuses in on certain target people and disparities and try to elevate the quality of knowledge, healthcare to the whole environment. And every 10 years, they make a new list, whether it's dental care, whether it's obesity, whether it's, getting immunizations. All of these things are followed closely. The one in 2030 is to have 95% of all children in the US immunized against childhood communicable diseases. So this is a government thing that's been made, that and then you'll see funds directed from the government to try to get this done. Vaccines, babies are born 2, 4, 6 months. We're getting 3, 4 at a time, right? We know that vaccines prevent diseases. We know some are oral, some are IM, some are sub-Q. Again, as nurses, knowing, are they room temperature? Do we need to keep them in the refrigerator? All of these things we need to know. So if we're giving an immunization, we know we're giving it accurately. With allergies, and if you're working in any sort of facility, allergies are things that happen, and they can have reactions from things that you knew that they were allergic, but they ate the food maybe still, and they go into starting difficulty breathing. Epinephrine should always be there and available, especially like when we're giving immunizations. There are new immunizations that we're giving. They also say that children should be watched for a little bit after. In the hospital I worked, any injection was 30 minutes. You had to stay just to try to avoid these things. You shouldn't give some vaccines if they're allergic to Baker's yeast. They shouldn't have Hep B. I have this intolerance something to yeast, so that's something they won't let me get. Eggs, it's the influenza and the MMR. Neomycin, which is an antibiotic, and there's the IPV, MMR, and varicella. So we need to know sometimes when we're giving immunizations, are you allergic to anything, any food? Very important thing to ask. So contraindications immunization. If you have a child who's immunocompromised, let's say they're having leukemia, do they get their immunizations? No, they'll be held. In pregnancy, some are held and some are encouraged. Depends on the physician to ask those questions. If we have bacteremia, meningitis, you have an infection, you're never going to give any immunizations with fevers or if you're sick. No, we just don't. If you're on corticosteroids, you are rendered immunosuppressed. If you are immunosuppressed, you can't get immunization. So it was one of those things that one of my students was asking me, I don't understand why corticosteroid. And it is that when you take steroids, you are rendered immunosuppressed. That masks signs of infections, right? And as I said, any history of fever or any contraindications to previous stuff will always take that into consideration. So bioterrorism and the child, well, we know that, stuff can be out there. I mean, they used to have, I remember years ago where they started mentioning bioterrorism and boxes were sent to the Senate and they thought it was anthrax and all of these things. This is what they're talking about. We know children, if exposed, just the nature, they're less immune system in them. They're going to be more vulnerable, and children are down low in the ground where usually the stuff comes from. And the thing about these antidotes to some of these bioterrorism threats, children haven't been tested accurately, and we don't know how to give them safely. Emergency preparedness. Now, I live in hurricane zone, right? I've had a big hurricane down here, and these are things that every year you make sure that you have. Always have supply of food, water, medications, your most important documents, have them locked up in a place where they'll be safe. And of course, you want your toiletries because the air conditioner is going to go out, the water is going to go off. Half your house here can be blown away, if not the whole thing. So you want to have something there that can keep you at least fresh. And the younger children need to know what happens. For instance, if you have that household where you have all of a sudden these tornadoes come up and you have seconds to respond, there should be drills to get those children to know what's going to go on. I mean, always have these out of state family call you afterwards, so they know if you haven't called, they need to go looking for you. I know that I had one heading to me down in South Florida. My mother lived 2 hours north, and I called her, and it ended up hitting her, not me. So at least we had communicated, and I found out where she was. She actually had taken off. Smart woman. And then children, personal IDs. Do they know their phone numbers too? Young kids should all know who to call. Remember, children have more body surface area because they have thinner skin. Know that they're not as strong as an adult body, so even their lungs can have problems of stirring up of dust and all of that. Again, closer to the ground, it's going to come into them, and that blood-brain barrier is going to be less there. So, as a nurse, always, I always say these things. Always keep the patient, the child, the parent with them safe and feel comfortable. You don't need to be judgmental. I mean, we're here as nurses to take care of something's going on with a child if it's in pediatric nursing. So we need to there to lend that support. Always provide privacy. Let them ask as many questions as they want. And again, if you don't know the answers, write it down and say, I'll come back and I'll let you know. I honestly don't know. A family or a child would prefer you say that than try to give them an answer that don't make sense. And then find out, how do you need to explain things on what educational level. You have some adults that learn very simplistically. So make sure that they understand for it, and let that patient know to take care and feel good about taking care of themselves. And HIV AIDS. We've slightly mentioned it a couple different places, but HIV and AIDS is you have infants born, usually infants born today. I'm going to first, before I go into all the things that go on, I had triplets at a clinical site where I worked, all girls. One girl had HIV, one had AIDS, and one had nothing. I've also seen infants born from HIV mother who, by 1 year old, auto converted and were negative. And that was the use of all those big antiviral medications. So HIV on an infant isn't always that death sentence as you would think today. We know if it is HIV, we know they have no immune system, it's failure to thrive. Their lymph nodes are all swollen up and they're chronic sinusitis, and they're really difficult to treat from infections. Then we see those things, the thrush, the pneumocystis, and the herpes and CMV, all of those things that can occur because of HIV and a diminished immune system. So again, how do we treat it? There's antiretrovirals, antivirals, those do help. And it is supportive. We hope that we can convert some of these young kids into zero, but there is no cure. And they do recommend, because their immune systems are nowhere, for immunizations. So, how was that for today? It was long, 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 long. I felt like I talked forever. Did I put anybody to sleep? Almost. No, Howard was pretty good. She was talking with me the whole way through. You kept me going, you and Clara. Does anybody have any questions about anything? I'm not going to get the Kahoots done today, that's for sure. So I will send that to you. I do have a couple appointments next week with some of you, so know that I'll be there. Brandy, I'll get back to you. Know that I am home this weekend. So, it's one of those weekends that I had a great week off and on with my kids. I got to hug them goodbye and watch them jump out of a perfectly good helicopter. It was probably one of the best experiences of my life. Watching your 6'4" son jump out of a Black Hawk helicopter.